Hello again, welcome. You are here to see tonight's webinar, Understanding and Navigating DCM. We will hear expert and patient perspectives tonight. I am Jan Rock. I'm the Director of Information and Education for the Foundation, and we're thrilled you could be with us tonight. All microphones are on mute upon joining. If you have any questions, please use the Q&A feature at the bottom of your screen. Next slide, please. The DCM Foundation's mission is to provide hope and support to DCM patients and families with dilated cardiomyopathy, and we do this through education, research, and advocacy. Next slide. So tonight's format is just a little bit different. We usually are very content heavy during these webinars. We like to provide all kinds of information and education for people. Tonight's webinar is a little bit different. What we wanted to do was allow plenty of time for patients and family members to ask questions. So an extended Q&A session is going to follow tonight's presentations, and you'll have the opportunity to ask questions of a heart failure cardiologist, a cardiovascular genetic counselor, and 2 DCM patients. So please enter your questions at the bottom of Zoom at any point during the presentation, and then we'll get to those a little bit later. Next slide. Tonight's agenda includes an overview about DCM with a heart failure cardiologist. We'll then talk a little bit about the link between DCM and genetics, and we'll hear about that from a genetic counselor. You'll then hear 2 DCM patient stories, and we will then have the informal roundtable chat with live Q&A. And again, we encourage you to put your questions into the chat feature at the bottom. Actually, it's the Q&A feature of Zoom. Thank you. Next slide. So our first presenter tonight is Dr. Kathy Crispell. Kathy is a cardiovascular disease and advanced heart failure and transplant specialist. She's also a board member with the DCM Foundation. Kathy did her training at Oregon Health Sciences University in Portland, Oregon, where she participated in research with Dr. Hirschberger and studied DCM in families. She was later recruited by Northwest Kaiser Permanente, where she served in roles as the Chief of Cardiology, Director of Cardiovascular Services, and Chief Medical Officer. She retired in 2015, but then continued to work part-time at the Portland VA Medical Center and at OHSU as an associate professor. And she does a lot of volunteer work, and she volunteers a lot of time for the DCM Foundation board, and we're thrilled to have her on tonight. So Kathy, thank you so much for being here. The floor is yours.
Thank you, Jan. Let me get my video working here. There we go. Okay, well, I'm going to have a lot of information that I need to get through pretty promptly tonight. And thank you for that great introduction. And it's great to have you join me again today, this afternoon and this evening for this talk. Well, let's go over some of the DCM basics. And some of you may know this information, but some of you may have a new diagnosis or know someone that's been newly diagnosed. So hopefully this will be new and good information for you to know. Next slide, please. So what does DCM stand for? It stands for dilated cardiomyopathy. Cardio meaning heart, myopathy meaning muscle disease, and dilated meaning to make bigger or larger. So it's a heart muscle disease in which at least the left ventricle of the heart becomes enlarged or dilated, but other chambers can also become dilated. To the right, you see a diagram of a normal heart, and the dark red represents the left ventricle. And above it is the left atrium, and on the other side is the right ventricle and right atrium. The left ventricle is the workhorse of the heart. It is the power horse of the heart, and it pumps blood to the rest of the body. So it's a very important structure. And if you look at this diagram, you see that there's a a nice amount of muscle that powers this left ventricle. To the right of that is a heart that has dilated cardiomyopathy. And you see that the left ventricle is enlarged, and the heart muscle surrounding that cavity is thinner. And so this left ventricle probably doesn't function normally. Above it, if you look carefully, you'll see that the left atrium is mildly dilated when you compare it to the normal heart to the left. So that's an example of dilated cardiomyopathy. Next slide, please. So what causes DCM? Well, there's two big categories or buckets of causes. The first category I call primary, and that indicates that there's an intrinsic problem with the heart muscle. That is, at the molecular level, there is a problem with the heart muscle and how it works. And people who have a genetic mutation that leads to the development of DCM, they fall into this primary category. Another subgroup of people who fall into this primary category are people that have been diagnosed with idiopathic dilated cardiomyopathy. Idiopathic means we don't know. So we don't know really what the underlying cause of their DCM is. And so we label them idiopathic DCM. I would venture to say that many people who fall into this category actually do have a genetic cause, but they may not have been tested or may not have been identified yet, or they may have a mutation that hasn't been discovered yet. So those are two major categories of this primary. The second big bucket is secondary. And that means that another problem or disease has damaged the heart muscle, and that can lead to DCM. And one of those diseases that can cause that is coronary artery disease, which is very common in the United States and in the Western world. And this is when the little arteries that sit on the surface of the heart and feed the heart its own blood supply and nutrients. It's when those little arteries get clogged up with cholesterol and obstruct the blood flow to the heart muscle. And if the blood flow is obstructed altogether, then that can cause a myocardial infarction, or commonly referred to as heart attack. When that occurs, heart muscle cells actually die, and they're replaced by scar tissue. And that leads to dysfunction and possibly the development of DCM, depending upon how big that heart attack is. Other kinds of problems that can lead to DCM include heart valve problems, toxins to the heart muscle, such as certain chemotherapy drugs, other metabolic diseases or abnormalities. An example of that is a disease called hemochromatosis, and infections and inflammation can also cause damage to the heart muscle and lead to DCM. Next slide, please. The DCM Foundation has a focus on genetic causes. And why is that? Well, that's because there's a big lack of awareness among people who have DCM, and there's a lack of awareness from healthcare providers about the genetic causes of DCM. Many healthcare providers are not aware that there are medical guidelines that state that people who have dilated cardiomyopathy that's not caused by coronary artery disease or a heart attack should be genetically tested and counseled. And we also believe that awareness provides hope to people that are affected with DCM. Next slide, please. I'm not going to go through most of the information on this slide because it's going to be covered by our next speaker, but I will say that we also have a focus on genetic causes because we want to increase that awareness so that people become more aware that there may be opportunities for them to participate or enroll in research studies that hopefully would increase our understanding about DCM and potential gene-based therapies. Next slide, please. So no matter the cause of DCM, the end result of DCM can be the development of the syndrome of heart failure. Now, heart failure itself is not a disease, it's a syndrome, and a syndrome is a constellation of signs and symptoms. Next slide, please. Some people in the audience may have had or have symptoms of heart failure. I love this slide. I'm not going to go through every single one of these, and I'm just going to point out a couple of major symptoms that are quite common in people who have heart failure. One is shortness of breath, and this is very common. And it can start off very subtle. It can be with, shortness of breath only occurring with exertion. But if the symptoms progress or as the disease progresses, the shortness of breath can worsen and occur even when you're not doing anything. And that includes shortness of breath even when you're trying to sleep. That's a very severe symptom of heart failure. Many people with a heart failure also retain fluid, and so they may notice, their feet or their ankles or their legs are swelling with fluid. The legs or ankles or feet may not, swell, but they may have swelling in other areas, such as the abdomen. And then swelling or edema, excess fluid, can accumulate in the chest, which is one of the reasons why people develop shortness of breath, because that's actually fluid in the lungs that causes that shortness of breath. Next slide, please. The most common way DCM is diagnosed is that an affected person presents to their healthcare provider with signs and symptoms of heart failure. And unfortunately, when that happens, the disease is already pretty advanced. To try to understand why this person has heart failure, certain basic tests are almost always done. And those include a chest X-ray, electrocardiogram or ECG, an echocardiogram, which is an ultrasound of the heart, and a BNP level, which is a blood test. Next slide, please. This is a still frame from an echocardiogram. An echocardiogram actually is an image study that is moving. So it actually shows the heart beating, contracting. But you get a lot of information from an echocardiogram, including the structure of the heart, how the valves are working, how the muscle is working. And even though we don't see that here in the still frame, what we do see is a very enlarged left ventricle. It's very dilated. It looks like someone has blown air into it, like blowing air into a balloon. And you can notice here on the right side of the heart, the right ventricle and right atrium look normal in size, but the left ventricle is quite enlarged. And if we saw a moving echocardiogram of this heart, we would probably see that this heart has a reduced ejection fraction, or its contractile function is not normal. Next slide, please. After the dilated cardiomyopathy is identified, like on an echocardiogram, then other tests may be done. And the reason why these other tests are done is because we're looking for any of those other diseases that can cause secondary DCM. Because if we identify any one of those diseases, it's possible if we treat that underlying disease, that we may be able to greatly improve the DCM, and in some cases maybe alleviate it. So one of the tests that is commonly done is a cardiac MRI, which provides a lot of information about the heart muscle itself. And then there's always, or almost, I should say, most often, there is some sort of evaluation for coronary artery disease, because I told you that was quite common. And people can have coronary artery disease and not know about it, and they can even have heart attacks and not know about it. So tests are done to look to see if a person has coronary artery disease. There are a lot of different tests that can be done to evaluate for coronary artery disease, but what's considered to be the gold standard is what we call a coronary angiogram or coronary angiography. Next slide, please. Some of you in the audience may have had an angiogram, and that's pretty common. And this is, again, a still frame from an angiogram. It's actually kind of a motion picture of how the blood is flowing through those little arteries that sit on the surface of the heart and how the heart is contracting. And in this still frame, though, we see that there is a really significant blockage here in this significant artery with two big branches coming off of it that's supplying the blood supply to the left ventricle. And if this is a heart that has DCM and the ejection fraction is reduced because the heart muscle is not getting enough blood supply, by opening up that blockage and restoring the blood flow through these big arteries, the heart muscle function may be restored back to normal. So that's why we look for these things. Next slide, please. Treatments for dilated cardiomyopathy can be complicated. Next slide, please. And I categorize treatments into two big categories. One is non-pharmacologic interventions or treatments, which means non-drug therapy interventions or treatments. Not going to go through most of the items on this slide, but I am going to point out that getting care from the right person or people for DCM, especially if you have DCM with a reduced ejection fraction and heart failure, is very important. And often this care is carried out by multidisciplinary teams, often led by a cardiologist or a physician with advanced training in advanced heart failure or in transplantation. And there may be other kinds of healthcare professionals that work on these teams to provide that care. On our website, you can go to Patient Support and Resources tab, open that up, and on the drop-down list, you can find a cardiomyopathy specialist. That'll take you to a page that you can put in some information, and hopefully that will help you to find specialists close to where you live. Next slide, please. Pharmacologic therapy or drug therapy is also just complicated on its own. Next slide, please. There are many drugs that can be used to treat dilated cardiomyopathy, but there are four major categories of these medications. And these medications, it's important for you to know, have been studied in thousands of patients prior to the release to the public at large. And these four categories of medications can help people with DCM and decreased ejection fraction live longer, have improved heart muscle function, and help people feel better and reduce their need for hospitalization. Next slide, please. The four major classes or categories of medications are the following: ACE inhibitors, ARBs, and ARNIs, and below that are some of the medications that are in this class. Please note that Entresto is in this class of medications. The next class are beta blockers, and on this first line here are the beta blockers that have been studied and shown to be beneficial in people with DCM, reduced ejection fraction, and heart failure. On this line here, this beta blocker, low pressor, very commonly prescribed for different cardiac conditions. It, however, is not one of the drugs that is indicated for DCM, reduced ejection fraction, and heart failure. MRAs include spironolactone and eplerenone. If you're on one of these medications, you're probably getting your kidney function and potassium levels monitored pretty carefully. And the fourth category is the newest class of medications, and these are the SGLT2 inhibitors. And these are drugs that were developed for the treatment of diabetes, but they were found to be very beneficial to people with heart failure. Next slide, please. So those four classes of medications are often referred to as the pillars of therapy, because everything else stands on top of those pillars of therapy. So additional therapies are added to these pillars. Next slide, please. So what are additional therapies? Well, additional therapies include CRT, which means treatment with a biventricular pacemaker, defibrillator therapy, which is actually isn't an active therapy, but it's a preventive therapy for appropriate people. Investigational medicines or devices are added to these pillars of therapy. And then if a person, if a patient who's on those pillars of therapy, their condition worsens, even though they're on all of the right medications from those pillars of therapy, or we have to begin to withdraw drugs from those pillars of therapy because they are too sick to tolerate some of those drugs anymore, then that's when we consider mechanical cardiac support, or VAD, and heart transplantation. Next paragraph, or next slide, please. So I'll close by saying that no patient paths are the same. Everyone has their own journey, and there may be similarities, but there can be a lot of differences from one person's story to another. And with that, I'll close and hand it over to our next speaker.
Oops, sorry. Thank you, Kathy. I'll take it from there for a minute. There are a couple of quick questions that came in, one related to the pillars. I'm going to say this wrong. Is lavabradine classed as one of the four pillars, and what type of drug is it?
Yeah, that's actually not in one of the four pillars. It is one of those additional therapies. So it's actually, it's not investigational drug therapy. It's but it is a drug that actually lowers the heart rate. And so one of the goals for people that have DCM and heart failure is to lower the heart rate. And many times that second class or pillar of therapy, the beta blockers, quite often are very effective at lowering the heart rate, but in some people they're not. They don't lower it enough. And so ivabradine can be added to try to lower the heart rate further. And so it's an additional therapy to the pillars of therapy.
Okay, great. And just one other quick question while we're here. Fred asks, can you expand on the anecdotal evidence that Jardiance helps people with cardiac failure?
Well, Jardiance is one of those SGLT2 inhibitors.
Mm-hmm.
And so there are very specific ones that have been evaluated. And so exactly how they work, no one really fully understands.
Oh, wow.
And so, we just know by studying many people that they truly have a benefit. They help people with heart failure. They can act. One way they do act is they help the body to get rid of fluid, that if you're retaining fluid, but they probably act in other ways that are very beneficial, and we don't truly understand exactly how they work.
Wow, that's fascinating.
Mm-hmm.
Okay, thank you. I'm sure we'll have a lot more questions for you in a little bit. Again, if people have questions, please drop them into Q&A at the bottom of your screen. Thank you so much, Kathy. We'll come back to you. So next slide, please. So I want to talk briefly before our next speaker about the link between DCM and genetics. They now think that about 50% of all cardiomyopathy cases in the United States have some type of genetic cause, but only 1% of patients get genetically tested. So this is why we really try to emphasize and draw awareness to this gap so that more people who have cardiomyopathy will get tested. The new guidelines from the American Heart Association and the American College of Cardiology recommend genetic testing if you have cardiomyopathy that's not caused by a heart attack or coronary heart disease. So again, If you haven't been genetically tested yet, please consider it. Talk to your doctor. Go to our website. The address will be at the end of the slides. It's geneticcardiomyopathy.org to learn more. And we'll talk next in more depth about the link between DCM and genetics. So next slide. So tonight's next presenter is Erin Miller. Erin is a licensed genetic counselor with the Cincinnati Children's Hospital. She works there in the Division of Cardiology, and she is an associate professor at the University of Cincinnati College of Medicine. Her clinical activities are focused in cardiovascular genetics, with specific interest in cardiomyopathy and other inherited heart diseases. Erin provides genetic counseling to people of all ages. Her research interests include the impact of clinical genetic testing and cardiac screening recommendations on family members. And without further ado, Erin, thank you so much for being with us tonight. And we'd love to hear more from you about this kind of complicated topic, but it's so important.
Yes, thank you so much for the introduction, Jan. It's my pleasure to be here, and thank you to the DCM Foundation for inviting me. Next slide, please. So I'm just talking with you briefly today, but what I hope to do is just provide you with some context and general information about what the genetic evaluation process can and should look like, so that you maybe feel more comfortable talking with your family members or talking with your healthcare providers about how genetic testing might fit into your overall care. So when we think about the genetic testing approach, I think one point of confusion for many people is sort of where to start. And so the first thing that really should be done is identify who the most appropriate person is in your family to have genetic testing. So for lack of a better term, the most appropriate person to have genetic testing is the most severely affected individual. So somebody that has a diagnosis of DCM, that's seen a heart failure specialist, that has had sort of a comprehensive workup with potential causes identified. Now, I'll say, I see patients of all ages. Like I said, I am at a pediatric institution. Oftentimes, my pediatric cardiology heart failure colleagues, the physicians here, will see a pediatric aged individual who's perfectly healthy that get referred because their parent maybe has a diagnosis of DCM. And so I'll end up actually seeing the affected parent and facilitating genetic testing for them so that we can better understand the risk, if any, for their children. So identifying the appropriate person is really the best starting place. And, in a perfect world, people would come to me with a specific category that Dr. Crispell identified, primary or secondary, but we live in an imperfect world. So sometimes I'm meeting with someone who has a diagnosis of DCM and maybe has some risk factors. Maybe they have high blood pressure or a diagnosis of diabetes, possibly they have sleep apnea. So sometimes it may not be as clear cut as that. We know exactly why you have heart failure, or we have absolutely no idea. You have no risk factors. More often than not, the area is a little bit gray. So I often really try to talk to individuals I'm meeting with about, well, how likely do we think a genetic cause is? And even if there may be other risk factors, there's sometimes still value in the genetic testing. So the starting point is important. And that information I'll talk about in a minute can be helpful for the affected individual. But the genetic testing results can also be really powerful for their family members. So the type of testing that we would offer the initial person in the family to be tested, the affected person, is going to be different than their at-risk family members once we have those initial genetic testing results back. So figuring out who should be offered genetic counseling and testing is important. The second is identifying the most appropriate genetic test. And the vast majority of the time, the test that I think is probably most appropriate with someone with DCM is what we call a gene panel. So that just refers to a group of genes that are being looked at that are specifically known to be associated with a diagnosis of DCM. There can be more comprehensive genetic testing in certain situations that might be appropriate, where we're looking at a larger group of genes or genetic material, and sometimes a more targeted test is appropriate. So if we've identified a genetic cause in an affected individual, we can do a very targeted test in their family members. There are other considerations here as well. So what is the cost of testing? What are the potential insurance implications? What may be the best laboratory to utilize? Not all genetic testing laboratories are created equal. There may be labs 1 through 5 that all say they offer a dilated cardiomyopathy gene panel, but the actual content of the panel, what is being evaluated, may look very different. Advance, please. So I can't be a genetic counselor and not show you like a cartoon of a double helix, right? But just so that we're all on the same page as we're talking a little bit about genetic testing, I often hear people say, I have the heart disease gene, or I don't have the heart disease gene, or I have the cancer gene, or I don't have the cancer gene. But we all have these genes. And some of you may already know this, especially if you've had genetic testing. But a gene is simply a specific segment or sequence of DNA. And what that gene does is it makes a protein, and the protein performs a function in our body. And when you have a change or a mutation in a gene, it either creates a scenario where there isn't enough of the normal protein, or the protein itself is abnormal and not working correctly. Next slide, please. So when you have genetic testing done, they are taking your DNA and they're comparing it to what we often refer to as a reference sequence. So we have really good information now about what the typical or standard sequence of a specific gene should look like. So you see in this cartoon, person 1 is supposed to have a C, and the individual that we're testing has a T. So one way to think about this, or how I explain it to people I'm meeting with, is that it's kind of like spell checking a Word document, and we're looking for a misspelling in a word that would cause it to lose its meaning or change its meaning. So we're essentially spell checking the DNA code of genes that are important for normal heart muscle function. Next slide, please. So how is genetic testing done? Well, every single cell of our body, skin cells, hair cells, brain cells, heart cells, blood cells, has all of our DNA code. It's in every cell of our body. Some of those cells are easier than others to obtain. So the vast majority of time, from a genetic testing perspective, we utilize either a cheek swab. These look like big Q-tips that you rub on the inside of your cheek and insert into a tube that has a little bit of solution. You screw the lid on, you shake it up. Sometimes just saliva is obtained, where you're actually spitting into a tube. And of course, we can also use blood. From a clinical perspective, most of the individuals I meet with, it's via telemedicine now. So we're just talking as we are now. And so a test kit is actually mailed to their house, and they collect the cheek swab or saliva sample at home, and they mail it back to the laboratory. So the logistics itself are probably the easiest part of the genetic testing process. Most of the time, the results take maybe 3 weeks or so. At the end of that time, someone should be discussing those results with you. They should share a copy of the result report with you. If you've had genetic testing and you don't have a copy of your results, I would suggest trying to get a copy and keep that for your own records. These tend to be things that can be hard to track down after the fact. I often provide a result letter that provides some additional guidance or recommendations or thoughts about the findings and recommendations for family members too. Next slide, please. So what are the possible results? First, we could get a positive result. I like to prepare people before doing genetic testing about how likely are we to find a cause. So positive in this case means we identified an underlying gene mutation that is associated with a risk for DCM. So sometimes the likelihood of a positive result is higher. Say, for example, if I see someone who was diagnosed at a young age with DCM, they have multiple affected relatives, that's a scenario where the likelihood of finding a genetic cause is going to be higher. Whereas if I see someone who was diagnosed at an older age, maybe has some possible risk factors, but nothing clearly causing it, no known family history, maybe the likelihood of a positive result is lower. So we try to have sort of a thought in mind about what's most likely to be found. The results could, of course, be negative. I think the thing to remember with negative, it means that a genetic variant was not found. A negative genetic testing result does not mean there may not be a genetic contribution for disease. So there are recommendations for family screening from a heart screening perspective. If someone with dilated cardiomyopathy and an unclear cause has a negative genetic test, we still recommend cardiac screening and imaging in their closest family members because those people may still have an increased risk of developing the same heart problem. Like with any medical test, it seems you can also get an uncertain result. So an uncertain result means a variant was found, but we don't have enough information about it to know if it's the cause of the dilated cardiomyopathy, or it could just be part of normal, what we would call benign genetic variation. And I often talk about sort of this continuum of when we're interpreting genetic testing results. The lights in my office just went off. I don't know if I'm here too late or what's going on.
Oh,
Sorry,
goodness.
all.
We can still see you.
I'll keep going. It's just I was surprised by that. So from an uncertain result perspective, sometimes it's uncertain and we really have no idea, but oftentimes I'm able to tell families like, I think this is trending positive, meaning there's good data about this variant. We just don't have enough information yet to say for certain. But I think that this is potentially the cause, but we're going to be more thoughtful about how we use this information until we know more. Sometimes testing additional family members for an uncertain result can be helpful. For example, if there's other people in the family with DCM, testing them to see, well, does this genetic variant actually, is it present in everyone in the family that has a diagnosis? That can be powerful information as well. So most causes of DCM have what we call an autosomal dominant inheritance pattern. Not all, but it's by far the most common. And this refers to the fact that we have 2 copies of every gene, one that we inherit from each parent. And with dominant conditions, just 1 copy of that gene has a change or a mutation in it. That's enough for that individual to be at risk or to develop DCM. The term autosomal refers to the fact that these genes are not on our X or Y chromosome, so the chance of passing this on or inheriting it is the same for men and for women. I think it was mentioned earlier that not having a family history of DCM does not mean that it couldn't be genetic. And so on occasion, we see what we call de novo gene variants or mutations. So someone has a positive genetic test, we test both of their parents, and neither of their parents have the variant. And these new genetic changes or mutations can occur in individuals. And so we do see that. It's not the most common outcome, but it certainly can happen. But once that person has a gene mutation, they have then a risk of passing it on to their children. 2 really important concepts when it comes to thinking about the genetics of heart disease, specifically DCM. One of them is called reduced penetrance. And it's the idea that not everybody with a gene mutation will develop the disease. And the penetrance is different for each gene and even sometimes for each variant. So just having a positive genetic testing result does not give you a diagnosis of heart disease. Only a cardiologist with appropriate heart testing can do that. But it gives us insight about risk and allows us to initiate early heart screening so that we can diagnose any changes in heart muscle function and initiate therapy before someone is already down the path of experiencing heart failure symptoms, like Dr. Crispell had mentioned. The other thing we think about is something called variable expressivity. So the age of diagnosis in a family, how severe the heart failure symptoms might be, or how severe the dysfunction might be, or how quickly it's progressing, can also vary within a family. So we have the same exact genetic risk with family members, but the way in which people present can be different. So that is sort of the things we often see. Next slide, please. So once someone has had genetic testing, and if we identify a positive result, so the genetic cause is identified, we talk about the best approach to testing family members. And so when we do initial genetic testing, and I go back to my sort of spell check analogy, It's kind of like reading maybe a novel, right? Looking for a misspelling in a book. But once a genetic mutation has been found in family members, we know exactly where to look. So we can do a targeted test. It's like knowing exactly what page, what paragraph, what sentence, what word to look in. So if there is a parent who has a mutation associated with DCM, every time they have a child, it's a 50% chance of passing on the gene mutation and a 50% chance of not passing on the gene mutation. So we often will use the genetic testing for healthy, unaffected family members to understand, well, who needs to be screened, and also to provide reassurance to say, yes, you have this family history of cardiomyopathy, but you are not at risk. It's also really important to confirm that other family members with DCM have the same gene mutation. These things are not as uncommon as you might think, and making assumptions that, well, if this person sitting in front of me has this gene mutation, then their aunt who has DCM must obviously have the same gene mutation. I think it's really important to make as few assumptions as possible, especially when we're talking about assigning risk and making recommendations for screening or even removal of screening. Next slide, please. So who are genetic counselors? I hope some of you on the call have had the opportunity to meet with a genetic counselor at some point in time, but we're healthcare providers that have training in medical genetics and counseling. We primarily guide and support patients who are looking to better understand how inherited diseases and conditions can affect them and their families. A large part of what I do involves interpreting genetic testing results and thinking about what does this result mean for this person in this time and place. Genetic counselors often specialize, not always. I specifically specialize in cardiology, but there are genetic counselors that specialize in other areas as well. And I just wanted to mention that, if you met with a genetic counselor for another reason, that the type of information you received or the attention to your family history related to heart failure might be different.
Wonderful. Erin, thank you so very much. We greatly appreciate your input on the topic, and we have some questions that are coming in. We're going to hold questions till the end now so that we can hear from the patients, and maybe you can see if your lights are working. Thank you, Erin. That was fantastic. So much information and so well presented. Next up, we have 2 DCM patients with us tonight. I'm thrilled to introduce to you Stephanie Fallon and Greg Roof. Stephanie is a genetic DCM patient who was diagnosed 41 years ago, and Greg Roof is a genetic DCM patient, and he received a heart transplant about 2.5 years ago. So to kick it off first, Stephanie, if you would tell us a little bit about your DCM journey, just like a summary, and then Greg will do the same, and then we'll take questions from the audience.
Okay, yeah, thank you, Jan.
Thank you.
I was diagnosed when I was 15 years old. I was trying out for the tennis team and couldn't run the laps that everyone could run. So the nurse said she heard something unusual and told my mom to take me to a cardiologist. And that was 1982. So
can I interrupt, Stephanie? Is your I don't see you on screen. I just want to
I
make sure.
don't either.
I don't know if your video's on. Okay. Well, we can hear you. Okay.
Yeah, I don't see anyone's video.
Okay, go ahead. Sorry.
Oh, it's okay. So the cardiologist gave me 5 years to live, which I think they tend to do that. I don't know if I really don't know why they do that anymore, because the medicine is really pretty good now. And hi, I can see everyone now.
Wonderful. We can see you. Go ahead.
Okay. And I was never told I could pass this down to my children. So in 2012, they offered to give me a genetic test, and I was tested, and I had the MYH7 gene mutation. 2 of my children have it. I have 3 children. 2 of them have it. My third one is just now going to get genetically tested because he was pretty afraid to do that before. And I have 1 grandchild that was actually diagnosed in utero with dilated cardiomyopathy. And we didn't know she had the MYH7 mutation until she was born, and they did genetic testing on her. But we knew before she was born, so she was able to get the right care and the right medicine. None of us have had heart transplants. We've been all managed with medicine, which has improved dramatically since I was 15 years old. And also my youngest daughter, she was born with a 10% ejection fraction. That's the pumping of her heart. And that was in 94. So back then we still really didn't have a whole lot of medicine advances. So she was on a lot of different trials and different medicine therapies, and she actually has improved. She's in the low 30s right now, which is wonderful for her. And my oldest child, she's in the 30s, and she has a defibrillator, and they're also being treated with medicine. And my grandchild is being treated with medicine. But one thing I want to say that's really, really important is not to make life hard on yourself. If you can't do something that day, don't do it. Just don't do it. Just rest, because there's always tomorrow. You can get that chore done tomorrow. And I stress that to my children and my grandchild with cardiomyopathy. It's okay. It's okay if you don't feel good. And you just have to explain to people about your disease and what's wrong. And most of the time they understand after they realize what's going on. So ask any questions you want. I'll answer them. And I see a lot of people here on my Facebook pages, and I want to say hi to everybody. And now I'm going to hand this over to Greg, who's another patient.
Great. Thanks, Stephanie. Thanks, everybody. I hope you can hear and see me. I know we were having, Stephanie didn't pop up. I know we were having some technical issues, but I think we can.
Yes, you're good. We can hear and see you. Yep.
Great. Thank you. So we're running a little long. I'll be really brief. Most of you know my story. We just want to mention that we can go 10, 15 minutes late. I know we have a lot of questions. So here we go. My story, genetic DCM, diagnosed 2014, TPM1, laminate 399. I had a lot of arrhythmia issues, electrical shutdown, had a lot of heart failure issues, worsening ejection fraction, 3 ICDs, ablation, cardioversions, so sort of VTAC storm at the end. Transplant. So I've kind of lived the journey from pretty much all angles. And so happy to answer any questions that you have. Appreciate everyone being on, the presenters tonight. Appreciate everybody being on as a participant. And I guess we'll go to Q&A now. And let's, if we can stay on, let's stay 10 or 15 minutes late for questions. So
awesome. Thank you so much, Stephanie and Greg. I just want to add 2 bits. First, Stephanie runs 2 DCM-specific Facebook groups online. Look up Dilated Cardiomyopathy under groups on Facebook and join her, groups. There's one private, one public. And also to let you know, Greg is also the executive director of the DCM Foundation and helped found it. So thank you so much for that. So let's take some questions. If everybody wants to come back on camera, I'm going to try to knock out a few questions in one. Kathy, for you, and we do have a lot here, 2 questions that are kind of in the same grouping. When you were talking about medications, what about anticoagulants and what about diuretics?
Yeah, I was just looking at the questions and saw those too. So again, neither one of those antiarrhythmic drugs and anticoagulants are different categories of drugs. Neither one of them fall into any of those 4 pillars of therapy.
Okay.
So there are additional therapies. Not everyone with DCM, a lower ejection fraction and heart failure require an anticoagulant or an antiarrhythmic. So they are additional therapies depending upon what kind of problems an individual may be experiencing, and what other kinds of risks an individual may have. So, so again, those are add-on therapies. They're not part of the 4 pillars.
Okay, all right, excellent.
And diuretics, and diuretics, the same thing. Diuretics can be very important medications, but they are not one of the 4 pillars of therapy.
Okay, all right, thank you. Just to let everyone know, because there are questions coming up, yes, this recording will be shared tomorrow, and it will also be available on our website with all other recorded webinars. So stay tuned for that. This question is for Erin. Erin, I see you there. Okay, great. I wasn't sure if you were still there. I recently found out my DCM is caused by a lamin A gene mutation. I'm lucky to have found out while I'm symptomless. My ejection fraction is 56%. I have a 10-year-old son and wondering about testing him and, when to do so.
Yeah, that's a great question. I think there's often good conversation that happens around what's the best timing for testing a child. And I don't think that you should feel that you need to do it now with LMNA specifically. It is more often onset in adulthood, 20s, 30s, 40s. But as we were talking about, there can be sort of extreme variability in terms of age of onset. So if you decide that you don't want to proceed with genetic testing right now, I think you might want to consider establishing care with a cardiologist and having some baseline cardiac imaging and evaluation done, or even meeting with a genetic counselor to talk about maybe what your hesitancy is or what might the risks be of testing an unaffected minor. That can look different for everyone. So I don't think there's one right time or one right answer for people. And I think it's great you're being thoughtful about what might be best for your family.
Wonderful, thank you. That's great input, great advice. Kathy, this is another for you. There's a lot of questions for the doctor. What is the difference between an ACE inhibitor and a beta blocker?
Well, that could be a whole hour's talk on itself, by itself. But it's basically, again, each one of there are 2 different categories of medications, meaning that the mechanisms by which they work are very different from one another. So they both work in different parts of the body and hormonal systems, basically, that become activated in the syndrome of heart failure. And they work on these different hormonal systems that are activated, and they help to suppress those systems. And so beta blockers work on one part hormonal system, and the ACE inhibitors work on another hormonal system.
Okay, great summary, and maybe another webinar topic for another time. This question is for you, Erin, from Miguel. Considering there is a good percentage of de novo genetic alterations in heart disease, what would be the recommendation for families who want to have a child and have a family history of heart disease?
So if you yourself are unaffected but have a family history of heart disease, and it's a close family member, so a sibling or a parent, would recommend that you be having periodic heart screening. I think it's really important to emphasize that not experiencing symptoms of heart failure does not mean that you may not have dysfunction. And so I think sometimes people maybe feel falsely reassured that lack of symptoms means no evidence of heart failure. That very well be the case. Not having symptoms is great, but you may still have the condition. We often want to test an affected person. So if you have a living affected family member, asking them if they've considered genetic testing, if they've talked to their doctor, if there's not someone available that has a diagnosis for genetic testing, we sometimes will do something called proactive genomic screening in healthy individuals that have a strong family history.
Okay.
It's similar to the testing we would do in an affected person, but it doesn't give us variants of uncertain significance. So it only gives us sort of clearly disease-causing findings. So that may be a good option to consider as well.
Okay. All right. Excellent. Quick question. I took the saliva test twice and it failed. Why is that? What does that mean? It failed?
So that's a sample failure. It doesn't mean that there's anything wrong with that person's DNA or genetics. It happens randomly sometimes, where even though someone correctly swabs their cheek or spits in a tube, that they don't get enough quantity or quality of DNA to do the genetic testing.
Okay.
And some people, for whatever reason, have multiple failures, and we don't have a reason for that. I would say you can try again, or you can just go get your blood drawn, which will have a less likelihood of a failure.
Okay. All right. Excellent. I'm learning so much tonight. I thought I knew a little bit about this, but
I'm sure you do.
if you're so kind. If a pathogenic variant, so if a gene mutation is found in someone, but they don't develop disease, why is that? Do we know?
Well, you are asking the question of all questions that I think we wish we could understand. I think that sort of the simplest answer is that we all have modifiers of our risk. And some of those modifiers are genetic, so background genetic risk, not variants that cause disease necessarily in and of themselves. They're sort of common variants in the population working together that maybe are protective in one person, or maybe place someone at a higher risk, or they're more susceptible. So there's probably genetic background modifiers, and we don't understand really how to test for how those are interacting or working together. The other is probably some environmental modifiers as well. Some things we have no control over, like age. The older you get, the more likely you are to develop disease. Other things like being exposed to a viral illness, or having high blood pressure. So there's environmental and genetic modifiers that impact each individual's person risk that probably explains in part why some people don't develop disease.
And Greg, you have that, you've told me in your family where you have some folks who've identified positive for like the lamin A gene, but they're not sick at all. And yet, you've gone through this entire process really starting in your teens, which you didn't realize. So it's fascinating.
Yeah, it's interesting how it works. And I don't think there's no real definitive answers. As I understand, I'm not a doctor, not a genetic counselor, but there are a lot of other factors that I guess would cause the gene to turn on or cause disease. And I think with research, they're finding out more and more and more, but there are no real definitive answers right now.
There's some similar questions to what we've already asked. Is there a difference in progression? This is for you, Erin. If both copies of the gene are affected versus one, considering that the pattern is autosomal dominant?
I would say that the general answer is yes. If someone has more than one genetic risk factor for DCM, we would anticipate that they would have more severe disease or earlier onset. It may be that it's like two variants in the same gene, or it could be different genes, both contributing. That happens less often. It's not common, but we have certainly seen it.
Okay, thank you. I love this. Wendy is a first-time listener. This sounds like, we're doing a late night call-in show. And this is to both Stephanie and Greg. Have you found that lifestyle impacts how you feel at all? Are there any foods that make you feel better or worse? So Stephanie, if you want to go first, and then we'll take Greg. Oh, you're on mute. I'm sorry. Can you hear us?
There we go.
Perfect.
I'm here. There are a lot of foods that make you feel pretty bad. Anything canned or processed or fast food that have lots of sodium,
Yep.
yeah, you tend to wake up the next morning and you gain 5 pounds in fluid. And that's when you call your doctor. But yeah, lifestyle does. I would say try to be as stress-free as you can. It's hard to do that if you have little kids or are raising a family, but you just have to take time and you have to learn what makes you feel better and what makes you feel worse. You just have to play around with it. And you like ham. I cannot eat ham, but I can have a piece of bacon. Yeah. So, you know, it everyone is different.
Listen to your body, right?
Yeah. Listen to yourself.
And Greg,
Greg?
what would you say?
Yeah, thanks, Stephanie. Yeah, definitely what you eat. So we have I'm a very, very strong believer that in any chronic illness that you're dealing with, and this obviously heart failure, dilated cardiomyopathy is a chronic illness, you need to be you need to live as healthily as you can. And we've had, I think, 3 classes at 20 Healthy Together program, 8 weeks. You know, it's about eating as well as you can. It's about staying as healthy and physically fit as you can. Again, always talk to your cardiologist or your cardiac rehab folks. It is the third piece really is about being as mindful and as mentally upbeat as you can. And these things all take this is a little work, this is a little practice, this is a daily routine, all these things. And then also spirituality. I mean, dealing with a long-term illness and thinking about the end of life as we do with these types of diseases. So I think absolutely yes. You have to go into this thing like a warrior. You have to be prepared as you can, and you have to work at those 4 things: eating well, being as fit as you can, being mentally upbeat, whether it's through working with a therapist, whether it's mindfulness, relaxation techniques, whatever it may be. And then again, I think being prepared spiritually, whatever spirituality you are. So big fan of that. Because I tend to find when you run through a disease, your physical state is here, but if your mental, emotional state and you're not doing the right thing physically, the stress, the angst of the battle with the disease, I think increases 3 to 4-fold. You can go through the disease as healthy as you can and as mentally relaxed as you can. It sucks. The disease is terrible. I get it. I've done the dance. But you have a lot of control over how you can manage that dance.
No, thank you. I think that's really helpful information. And there's some information on our blog, some of the stories that you've told about, what you've done to stay healthy and fit, Greg. And Greg's a big fitness buff, so he works out no matter what, no matter how he's feeling. So that's helped him, I think, tremendously too.
Which may not be a real positive thing with lamina too. So that's all.
Yeah, well, in moderation. Talk to your doctor, please.
I never did it in moderation, so maybe that's why.
Who knows? I will just mention, Tina is saying she's recovering from a case of severe bronchitis. Sorry to hear that. Glad you're feeling a little bit better. It sounds like you're recovering. And Kathy, this is for you. Her doctor had said that she can't take over-the-counter meds with, I'm going to say this wrong, phenylephrine. Did I say that right? Which is an ingredient in many over-the-counter and cough meds. Do you want to speak to that just for a quick second? Because I'm sure there are other folks, you might recommend the same thing, not to take those kind of meds.
Yeah, a lot of those medications can increase blood pressure and the heart rate. And so, depending upon the severity of your DCM and your symptoms, and that's probably not well advised for most people. I mean, a lot of the, again, one of the pillars of therapy are those beta blockers, and those beta blockers help to slow down your heart rate, and also the at least 2 of the other pillars of therapies help to lower blood pressure. So if you're taking other drugs that kind of counteract, the therapy that you're on, the very important drug therapy that you're on, that could potentially be detrimental. So that's why it's not recommended that you take certain over-the-counter medications with those substances included.
Excellent. Okay, thank you. And please feel better, Tina. And thank you for joining us tonight, even though you weren't feeling well. Erin, this is for you. With the advancement in genetic research and treatment, do you feel in the future it will be possible to eliminate faulty genes before they're problematic?
So there are new technologies that are available that essentially allow for what we call gene editing. The technologies are called CRISPR-Cas if you're interested in a Google search or reading more. And so I do think that there's a few ways to think about treating genetic disease, right? So, and there's lots of ways to think about gene therapy. I think that we're moving in that direction. There are challenges because if you think about the way in which genes and proteins are expressed, even though our genetic material is in every cell of our body, there are certain genes that are important for brain function or heart function. So there's a sophisticated system of turning genes on and expressing genes and not expressing genes. And so I think that is one of the major challenges in how do we repair or address one problem without affecting an entire system. So there's lots of ongoing research and thoughts about how we might be able to edit genes or even use viruses to provide someone with a normal protein or normal gene functions through viral DNA. So there's different mechanisms and lots of research that's ongoing. So I am hopeful about the future of sort of addressing the specific genetic problem, but we're not quite there yet from a clinical care perspective.
And I will just add, thank you so much for that. It really provides so much hope to people. And for anyone interested for additional information, please visit geneticcardiomyopathy.org. We developed this website. We've worked with a number of top companies that are working in this space. And there's a whole section now on genetics. And we're building that out more this year to include information about clinical trials that are coming and so forth. So it's really fascinating and the amount of science that's coming and the speed at which this is coming. So, but you have to know your genetic mutation first to be able to know if you can, receive any of these treatments down the line. So, so thank you for that. Lots of thanks for the answers on lifestyle. So thank you, Stephanie and Greg. This is interesting. I'm the first in my family to be diagnosed with DCM 4 years ago. My maternal grandfather died at 50. On his death certificate, he was diagnosed with an enlarged heart. Do you think this is what they called DCM back in the early to mid 1900s? Kathy, I'm not sure if you have an answer for that. Is that what they used to call it?
They used to call it a lot of different things.
Yeah.
And so, one of them, DCM, as I showed in my presentation, the heart does enlarge, it dilates. So, whoever filled out the death certificate may not have called it dilated cardiomyopathy at that time, but it could have been called just an enlarged heart. And when taking a thorough family history from a family, when you want to go back generations and try and get as much information about previous generations. Was anyone in your family diagnosed with enlarged hearts or heart failure? Dropsy is another word that was used to characterize conditions that could have been dilated cardiomyopathy.
Interesting. Okay.
I might just add, in case it's helpful for people, that I look at a lot of sort of death certificates and autopsy reports, that death certificates in general are not very helpful or accurate a lot of the time. Sometimes that's the only information we have, and some information is better than none. But asking questions about, was there an autopsy done, trying to get a copy of the autopsy will be much more informative. Or even questions like, Were they sick before they passed away, or was it sudden? That doesn't always help, but some of the context around someone's health before they passed away can be informative. And those are things I ask when I'm taking a family history too.
That's good to know. So as I dig in my ancestry.com, I'm not just getting wrong information. Okay, let's see. I think we have time for one more question. This is interesting and it may be a little complicated, but why would other family members who have already been diagnosed with DCM and heart failure not be genetically tested? And we do see this a lot, which is, I think, a travesty, but I was tested and no markers were found. My mom and twin sister both have the same condition, yet they are not being offered genetic testing. I wonder if the three of us have some marker that's not yet been discovered. Just seems odd. The three of us have the same condition. Would it be beneficial for them to have genetic testing? Erin?
So that's a great question. So my guess is that you had an initial dilated cardiomyopathy gene panel. Results were negative or uncertain, it sounds like, and someone stopped there. So I think this is a scenario where considering additional or expanded testing might make sense. And maybe for you in particular, like thinking about I haven't looked, I would look at medical records of your family members and say, okay, do they have another reason? Who would be the best person to test? But maybe like a genome or exome sequencing done as a trio, so they can utilize all of your samples to try to see if there might be a shared genetic cause. And, this is not necessarily something that I would recommend for everyone. Sometimes a normal test is a normal test, but when there's a strong family history, I think it's important to look further.
Okay, excellent.
And if I could add something from sitting in my seat for the last 7-8 years and putting the geneticcardiomyopathy.org together and what I've seen in hundreds, if not thousands, of patient conversations. Unfortunately, the vast majority of cardiologists don't understand genetics in cardiomyopathy. And they aren't equipped to do the testing, and they aren't equipped for, I think, Erin, you're a cardiovascular genetic counselor. There's probably 6,500 genetic counselors in the United States, and there's about 400 that deal specifically with cardiovascular, which is amazingly low. So what we really recommend, so don't expect your cardiologist to understand genetics. They probably do the right thing. I'm calling them out. The guidelines say if you're diagnosed with idiopathic cardiomyopathy, you should get genetically tested. But again, most cardiologists don't understand it and don't have the ability to do testing. What we recommend, if you can, it's very simple. Go to a heart failure center. So Google search heart failure center near me. Normally, academic centers, university, hospitals, things like that will have a heart failure center. They're going to be a lot better equipped to understand genetics and cardiomyopathy, treat it, and get you the proper genetic testing. But unfortunately, at this time, we're working really hard with there's Heart Failure Society of America. There's a lot of groups we're working with to change that, and with our own campaigns. But right now, don't expect the majority of the time to get good advice on this. That's what I've seen. And so Google Heart Failure Center near me, and I think you're going to have try to get in, and you're going to have a much better shot at finding someone that really understands this. More fully.
No, thank you. Thank you both. It's such an important topic. And again, you're going to continue to see information come out from the DCM Foundation and from the Genetic Cardiomyopathy Awareness Consortium. And I just want to say thank you all for staying on a little bit late. We just so appreciate all of you being here tonight to present. And I hope wherever you are, you're staying warm, because I know most of the United States is in a deep freeze and the rest of the world, I'm not sure what's going on. So anyhow, thank you all for being here. And Justine behind the scenes helping with the tech deck. Justine, if we can go back to the deck, I will say goodbye to all the speakers for now. Thank you again. And thank you to our sponsors. We just greatly appreciate the support of every single one of the companies whose logos you see listed here. We work very closely with them all year, and we will continue to provide you additional content throughout the year related to what's coming up for genetic cardiomyopathy. Next slide. Thank you for attending. I will roll up this webinar recording and it will come out tomorrow. If there are any questions we didn't get to tonight, I will be gathering answers for those and emailing you individually to get answers to those questions. So again, to learn more about dilated cardiomyopathy, please visit our website, dcmfoundation.org. All kinds of fantastic information on there that's vetted, that's accurate. Don't Google about DCM, just go to our website. To learn more about genetic testing for DCM, please visit geneticcardiomyopathy.org. And to learn about genetics of DCM in general, please visit that website. There's all kinds of great information, as well as information about our prior webinar recordings on the topic that you might find interesting based on these questions we've had tonight. So next slide. And please save the date. Our next webinar will be on Wednesday, March 6th. We do not have a webinar in February, from 6 to 7 p.m. Eastern Time. And the topic will be Help Us Save Lives, Become an Advocate. We are going to unveil an advocate kit for anyone who wants to spread the word, which is really important about genetic cardiomyopathy. And I think a few of you will be on there based on your questions tonight. So thank you again. Stay safe, be well. And yeah, just thank you so much. Please spread the word about the DCM Foundation and geneticcardiomyopathy.org. We need more people involved. Tell your doctors, tell your medical providers, your family members, and thank you so much. We'll see you in March. Okay, take care. Have a good night. Thanks again.